Hi everybody, welcome to our module on metabolic acidosis. So the metabolic acidoses are the most complex set of acid-base disorders, and that's because there are so many different etiologies of metabolic acidosis. They're also complicated because you have to calculate something called the anion gap, which splits them into two distinct groups of etiologies. So in order to understand the anion gap, let's first talk about the Chem 7. So when physicians say I ordered a Chem 7, what they mean is that they sent blood work on a patient to check the sodium, the potassium, the chloride, the bicarb, the BUN and creatinine, and then finally the glucose. And the way house officers and physicians write this in their notes in the hospital is they use something called the fishbone, which I've drawn on the screen here. So it's this little set of crossed lines here, and they always write the numbers in the same place. So they always write the sodium in the top left corner here, and the potassium down here, and the glucose over here, and all the other numbers where I've shown you on this figure. So get familiar with the fishbone so that when you're rounding in the hospital and you see something like this in the chart, you will know that 103 is the chloride and that 1.0 is the creatinine. They're always written in the same place. So once you know the Chem 7, you can determine the anion gap. And to understand the anion gap, let's draw a picture. So imagine you have a tube of blood right here, and it's filled up to here with blood. In that plasma, you have some elements that are positively charged and some elements that are negatively charged. And there's a mixture of these. And the total number of positive charges has to equal the total number of negative charges. Blood is not a battery. It does not generate positive or negative charge. It doesn't shock you when you touch it like something that's accumulated static electricity. So all positive and negative charges must be equal inside the plasma. So once you understand that, it's easy to understand the anion gap. The anion gap is the difference between the positively charged ions and the negatively charged ions. Now in reality, the difference is zero. The negatively charged and positively charged ions must equal one another, but it turns out we don't routinely measure all of the positive and negative ions. So if you take the routinely measured positively charged ions and subtract the routinely measured negatively charged ions, that will give you a gap, and that's called the anion gap. Now, to make this even more confusing, the routinely measured positively charged ions only include sodium. We don't count potassium. So the only positively charged ion that counts towards the anion gap is sodium. The only negatively charged ions that count towards the anion gap are chloride and bicarbonate. So if you look at our fishbone at the bottom of the screen here, to calculate the anion gap for a given patient, you take the sodium level and subtract the chloride and bicarbonate level, and that will give you the anion gap. And a normal value is anything less than 12 plus or minus 4. In a board question, if they're describing a case with an increased anion gap, the anion gap will usually be very high, like 18, 20 or higher. Anything close to 12 is considered normal. So for this example at the bottom of the screen here, if you wanted to determine the anion gap, you would take the sodium of 140 and subtract the chloride and bicarbonate of 103 and 26, and that would give you a value of 11, which is a normal anion gap. So now we understand that the anion gap comes from unmeasured ions. Well, what are those unmeasured ions? Well, they are things that don't appear in the Chem 7. So they are things like calcium, magnesium, and some other minerals. These are all cations that have a positive charge. And then there are also many anions, which are things with a negative charge. And these are mostly proteins like albumin and also phosphates and sulfates. Now, it's very high yield to know that the negatively charged albumin is predominantly responsible for the anion gap. It contributes more to the anion gap than anything else. And once you understand that, it's very easy to appreciate that a low anion gap can be caused in patients who have hypoalbuminemia. Remember I said that normal is less than 12. Patients with very low albumin may have an anion gap of 6 or 5 or 4. One other condition that sometimes causes a low anion gap is multiple myeloma. So in multiple myeloma, when patients make IgG antibodies, these are cationic. They have a positive charge. So they will push other cations like sodium out of the plasma, and they may also draw in other negatively charged ions like chloride. This will shrink the anion gap and give you a small anion gap. So normally in acid-base problems we talk about a normal or an increased anion gap, but there are a couple special scenarios where you get a small anion gap, and those are hypoalbuminemia and multiple myeloma. Those are the two you're most commonly asked about. So why does the anion gap matter so much in acid-base disorders? Well, the answer is because the anion gap splits metabolic acidosis cases into two distinct groups of causes. If you have an acidosis primarily from the loss of bicarb, the body will compensate with retention of chloride. Remember, the number of negatively and positively charged molecules has to stay equal in the plasma. So if you lose bicarbonate, the body will compensate by increasing the amount of chloride, and this maintains an equal amount of negatively charged molecules to compensate for the positive ones. So the anion gap is sodium minus chloride plus bicarb. If your acidosis is from the loss of bicarb, but then you retain chloride, the result is that the anion gap remains normal. On the other hand, if you have an acidosis from primarily the retention of an acid, for example keto acids or lactic acid, the bicarb will fall without a rise in chloride. Instead of chloride, you'll get a rise in some other anion related to the acid to compensate for the fall in bicarb. So since the anion gap is sodium minus chloride plus bicarb, in these acid-base problems, the bicarb falls, but the chloride does not rise. Therefore, you get an increase in the anion gap. So the anion gap splits metabolic acidosis cases into two distinct groups with these different etiologies. So another way to think about it, and I just want to emphasize this because it's an important point, when the bicarb falls, something negative must rise to make up for that loss of negatively charged bicarb. We have to maintain the balance of negative and positive charges. In a normal anion gap acidosis, the chloride rises, and chloride is part of the anion gap. That's why the anion gap stays normal. In a high anion gap metabolic acidosis, unmeasured acids rise, and that's what makes up for the loss of negatively charged bicarb. So just to make this point very clear, let's go over two quick cases of acidosis problems. The first one's at the top here, and you see that the pH is 7.31, and that's reduced, so we're dealing with an acidosis. So the first thing I do is look at the bicarb. The bicarb here is 16. That's always written in the middle of the bottom of the fishbone. So a bicarb of 16 is low. Normal is 24, so we're dealing with a metabolic acidosis. So as soon as I see I have a metabolic acidosis, what I do is I just look up at the chloride. This chloride is 108, which is increased. Normal is 95 to 105. So I already know that most likely this is a non-anion gap metabolic acidosis because the chloride level is high. We can go ahead and calculate the anion gap. It's 134 minus 108 minus 16, which is 10, and that's normal. But we already had a pretty good idea this was going to be normal because the chloride was up. The second case has a pH of 7.27. That's also low, so this is an acidosis. We look at the bicarb and it's 11. That's reduced, so this is a metabolic acidosis. Then we look at the chloride and we find that it's 93. That is not elevated. In fact, that's a little bit low. Normal is 95 to 105. So because the chloride is not increased, I know that we almost certainly have an anion gap metabolic acidosis. To confirm that, I calculate the anion gap. It's 132 minus 93 minus 11, and that works out to 28. So it's an anion gap metabolic acidosis. So my point in showing you these two cases is to let you know that the chloride largely tells the tale. When the chloride's up, you almost always have a non-anion gap metabolic acidosis. In fact, those acidosis problems are sometimes called hyperchloremic metabolic acidoses. When you have a normal or reduced chloride level, then you almost certainly have an anion gap acidosis. Now let's talk about Winner's formula, because Winner's formula is critically important in determining whether the respiratory compensation for a metabolic acidosis is appropriate. So when you have a metabolic acidosis, no matter what the cause, no matter what the anion gap, there will be a compensatory respiratory alkalosis. The body will begin to hyperventilate and blow off carbon dioxide, and this will lower the PCO2. Winner's formula tells you the expected decrease in PCO2 for a metabolic acidosis. If your actual CO2 does not equal the expected, then you have a mixed disorder. It means you have a concomitant respiratory disorder in addition to the metabolic acidosis. So the bottom line is that you need to check Winner's formula for all metabolic acidoses to make sure that the respiratory compensation is appropriate. And I've written Winner's formula down here. It's 1.5 times the bicarb plus 8 plus or minus 2. One other measurement that's very important in metabolic acidosis problems is called the delta-delta. It's also called the delta ratio. And this applies only to anion gap metabolic acidoses. If you have an increased anion gap acidosis, the increase in the anion gap should be similar to the fall in the bicarbonate level. So you can calculate the change in anion gap by taking the patient's anion gap and subtracting 12, which is a normal anion gap. You can calculate the change in bicarbonate by taking 24, which is a normal bicarbonate, and subtracting the patient's bicarbonate. The ratio of the change in anion gap to the change in bicarbonate helps you assess for a secondary acid-base disorder. This is used to check for a concomitant metabolic acid-base disorder. Remember, Winner's formula, which we just talked about, tells you if there's a concomitant or secondary respiratory disorder. The delta-delta ratio is going to tell you if there is a concomitant or secondary metabolic disorder. So for example, in an increased anion gap metabolic acidosis, you can have a concomitant metabolic alkalosis. The only way you're going to uncover that is by determining the delta-delta ratio using the formula down here. So once you calculate the delta-delta, you look at the ratio. So a delta-delta of 1 to 2 is normal, and this means that there is no secondary or concomitant metabolic acid-base problem. If the delta-delta is less than 1, this means that there is a secondary non-anion gap metabolic acidosis. This happens when the bicarb is too low. So the bicarb is being driven down by the anion gap metabolic acidosis, but also by another metabolic acidosis, making the level too low. If the delta-delta is greater than 2, it means there's a secondary or concomitant metabolic alkalosis or a pre-existing respiratory acidosis. This happens when the bicarb is too high. So you have an anion gap metabolic acidosis, but the bicarbonate level is higher than expected. The two reasons that occur is if you have a concomitant metabolic alkalosis, or if the patient has a pre-existing chronic respiratory acidosis. This means they chronically retain CO2 in their lungs and they walk around with a high bicarb from the renal retention. Either of these two acid-base disorders can give you a high bicarb, and that's why you end up with a delta-delta greater than 2. So just remember that you use this equation in all anion gap metabolic acidoses to determine whether there is a concomitant or secondary metabolic acid-base disorder. So it's easiest to understand this if we consider a hypothetical example. So suppose a patient has a pH of 721. That's a low pH, so we have an acidosis. The bicarb is 12, so a low bicarb and an acidosis is a metabolic acidosis. And then the sodium is 150 and the chloride is 96. So from these numbers we can calculate the anion gap, and it's high at 42. Recall that normal is 12. So the delta anion gap is the patient's gap minus a normal gap of 12, and that works out to 30. The delta bicarb is a normal bicarb of 24 minus the patient's bicarb of 12, and that works out to 12. So the delta-delta ratio is 30 over 12, and that's 2.5. This is too high, so that means the bicarbonate level is too high. There must be some concomitant disorder making the bicarbonate level too high. And the two things that can raise the bicarb are a concurrent metabolic alkalosis or a prior chronic respiratory acidosis. So we must have one of these two things going on. And the delta-delta ratio has allowed us to uncover this in the setting of an anion gap metabolic acidosis. So for the rest of this module, I'm going to discuss specific causes of metabolic acidoses, and I'm going to start with the non-anion gap metabolic acidoses because those are the simplest. So there are 6 main causes of a non-anion gap metabolic acidosis, and I've listed them here. So the first one is diarrhea, and this is easy to understand because you lose bicarbonate in stool, so patients who have diarrhea will lose the bicarb and they will get a non-gap acidosis. Another one is acetazolamide. So this is a carbonic anhydrase inhibitor that blocks formation and resorption of bicarb in the proximal tubule. So when you can't resorb bicarb, you lose bicarb, and the result is an acidosis. If you are taking spironolactone, which is an aldosterone blocker, or if you have Addison's disease where you don't make aldosterone, you lose the effects of aldosterone. And one of the effects of aldosterone is to excrete H+ effectively. So when you can't excrete it, you will retain it. And when you retain hydrogen atoms, you develop an acidosis. If you infuse saline into a patient, you dial down the renin-angiotensin-aldosterone system. This gives you a low aldosterone level. And anytime you have a low aldosterone level, you don't excrete H+ and you retain acid. And this can give you a metabolic acidosis. Patients who are receiving intravenous nutrition, that's called hyperalimentation, can get a metabolic acidosis. This is because the metabolism of some of the nutrients in hyperalimentation create hydrogen chloride, which is acid, and this lowers the pH. This is often offset by adding bicarb to the intravenous nutrition for hospitalized patients. And then finally, if you get a renal tubular acidosis, you can get a non-anion gap metabolic acidosis. And I talk about all these disorders in a separate module. So for the rest of this module, I'm going to discuss the anion gap metabolic acidoses, and these are the most complicated acid-base disorders to understand and remember because there are a lot of causes. So recall that the anion gap is sodium minus chloride plus bicarb. The bicarb is going to be low in a metabolic acidosis